One of the areas where I find doctors get very confused is TMJ diagnosis and treatment. For us, it's an integral part of myofunctional orthodontics. If you have poor oral function, soft tissue function, nearly always you'll have some sort of TMJ disorder. So let's look at how we break it up in our longer lecture, and then we have to define TMJ. A lot of doctors don't really know exactly what we're talking about in terms of the broader aspect of TMJ dysfunction. What causes it? How do we evaluate the patient? What's our diagnosis? We've got to keep it simple here. What are the treatment options? You really have to communicate with the patient, tell them what it's all about, and how do we make it work in practice. So Costin, 1934, I was brought up understanding about Costin syndrome. He was really the first to say, okay, this is a dental problem treated dentally, but really many medical symptoms. And we know the symptoms are pretty much as wide as you might want to discover. Many patients have just a clicking joint, others have headaches, neck pain, all sorts of dysfunction. And Costin noted that for all the neurological problems that they may have. And we now know that's primarily because of muscle dysfunction. So when we look at the joint, this 3D shows it's quite a complex joint. Its function is quite different from you might expect. A lot of people think that doctors think it's a rotational movement. In fact, Fonda showed that the opening and closing of the mandible is pivots around C1 and C2, so it's an integral part of cervical function as well. This is why we find many patients get neck disorders as well as TMJ disorders. So it's focused many times around the joint, but really the symptoms aren't related to the joint. The symptoms are the muscles, the craniomandibular muscles, and we'll show you that and how to diagnose it. Patients get many symptoms. What's TMJ? It can be anything you like. It's a craniomandibular cervical dysfunction, as far as we're concerned. It can be a clicking joint. It can be severe internal or intracapsular issues. But most patients have a wider number of symptoms, including neck, head, and shoulder pain. That can be confusing for the dentist because we're not used to treating these areas outside the mouth, but really the treatment is still internally, correcting the myofunctional habits. We break it up into intracapsular and extracapsular. Most patients have a bit of both, so they can be just a joint issue or they can be a wider neuromuscular issue, and most of the time we're looking at the neuromuscular side. And that's where the multiple pains come from. A lot of doctors think that the patients are crazy. Many times where the doctors are making them crazy because they can't effectively define and diagnose the problem. And we'll show you how to palpate the muscles and joints in a moment. But yes, keep in mind that the muscular pain is widespread. What causes it? Well, the myth is many dentists think it's just grinding your teeth, and I don't think this is a significant factor at all. Many times they tell patients they need to wear a splint to stop them grinding their teeth, but really it's not a significant etiology as far as I'm concerned in terms of causing TMJ disorder. Certainly any trauma to the joint is going to cause a TMJ dysfunction. Accidents, falls, whiplash injuries, all contribute to TMJ disorder, but it's so widespread it can't be just traumatic injury to the joint. So we can understand, yes, if we have a blow to the jaw, that's going to cause damage. But also, what about incorrect swallowing pattern? Mouth open posture, a normal swallow, there's no distalization of the condyle. Incorrect swallow, a mouth open posture will distalize the condyle twice a minute. So there's the trauma to the joint, there's the cause of the TMJ disorder. I showed you this before. If you look now, start looking at function in patients, even children, you'll palpate the joints and they'll have the precursor for TMJ disorder. But anything that distalizes or pushes the mandible back is going to cause this TMJ disorder. Most common is myofunctional. And this relates to the broader picture. We see these patients have poor posture. Roccabardo was the first one to discover the association between class 2, forward head posture, and craniocervical issues. So these patients, even the younger ones, have poor posture, and we can help them correct that by correcting their incorrect swallowing patterns. So you'll see these children, particularly who have TMJ disorder, very fidgety. They cannot swallow with the head sitting correctly on the spine. So a normal swallow, there should be very little movement, rocking back and forth of the head on the spine. Reverse swallow, you'll see, as we just showed you, quite severe action. And that's why the muscles are in dysfunction all the time, they're overworking. Simple explanation. How do we evaluate the patient? This is our patient evaluation form, which we have on a CD with our patient education system. Take on everything. The more symptoms they have, the more likely it's a TMJ disorder. And here's the muscles that we palpate. Basic, keep it simple, temporalis muscle, masseter muscle, palpate and see these are tender. Usually they're more tender on one side than the other. Lateral pterygoid, medial pterygoid, and then on to the sternocleidomastoids, and then you go on to the joint. The function of the joint, measure mouth opening, see if there's any clicking, some palpation. You palpate the joint and see if there's pain on palpation of the joint. But as I said, don't focus too much just on the joint issues. It's the muscular dysfunction that's important. And keep in mind that we're dealing with quite a complex system, and we need to really understand the anatomy and physiology. So please learn more about the muscles, and that will give you a much better understanding of how to treat these patients. How do we diagnose it? Best way is a muscle and joint palpation procedure. Again, temporalis, masseter, and you'll find that the tenderness usually on both sides. Lateral pterygoid we palpate externally. Sternocleidomastoid, you can see the patient is in quite a bit of pain. Onto the trapezius and posterior cervicals. Write all this down. You need to analyse which side is more tender, left or right. And our diagnostic procedure is the TMJ appliance. They put the TMJ appliance in, we wait a few minutes, get them to relax, and you go back and repalpate the same muscles. And to the patient's surprise, maybe at your surprise, the muscles are all less tender. Two reasons for that. You're decompressing the joint and you're stopping the tongue and the lips pushing the mandible back. So instantly the pain is relieved. So there's your diagnosis. Tick. If all the muscles are less tender, straight away, they won't be completely out of pain. That's your diagnosis. So what are our treatment options? 50% of patients are happy just using a TMJ appliance. Certainly if you don't have any intracapsular issues, TMJ appliance for 3 to 6 months will resolve a lot of the issues. We review the patients after 1 and 2 months and see how they're going. If the patient has 50% relief of their symptoms, that's the treatment. Why does it work? It unloads the joint, aligns the jaws, brings the mandible forward, corrects midline shifts, corrects tongue position, stops the myofunctional abscess. That's the key to it. We're talking about myofunctional issues here. Prevents tooth grinding. It's soft and flexible, easy to use. In addition to that, if we have some missing teeth or we have an intracapsular issue, we use a TMD appliance. This is used less frequently. It's a moldable appliance, but if you need to make something that the patient can wear 24 hours a day, use a TMD appliance. They're the most commonly used appliances. We also have another appliance for bruxing, which is called the Bruxigard. It's again moldable in place, and we also have a appliance for sleep disorders or patients who are breathing through the mouth all the time, it's a higher appliance with more breathing holes in the front. More information on the website. So further treatment options have to be explained to the patient. We have a CD which is our patient education CD for the TMJ patient, and if they don't get good resolution of symptoms or they've got missing teeth, we'll make them a splint. But these days the most common treatment is doing molar build-ups. We build up the 4 molars on the lower with composite, maybe 2-3 millimeters, and that gives good joint decompression, and also it helps to realign the occlusion. The clinical application of the TMJ appliance system is all about keeping it simple, good patient education, and not using complex appliances or techniques. And that makes it easily applied in your practice at any time.